Research and Education Foundation, being relayed through OrthoTV. Today we have Dr. Vikas Agashe from Hinduja Hospital, Mumbai, who needs no introduction because he's done multiple of these webinars before. And he's going to talk again on his favorite subject, which is infection, but it's going to be an interactive case-based discussion today. So over to you, Vikas. I'm sure all of us are going to enjoy your presentation. Thank you.
Thank you very much, John and Janki, and all the people who are attending. This would be an interactive session, so I would request all of you to switch on your videos and audios. Audio, in fact, whosoever is answering can put on, but please start your videos. And I will start with a very, very straightforward case. This is something which we have already discussed, that this patient has an insufficiency fracture on the medial aspect of femur. Okay. So this is likely to be, what is it? What is the diagnosis? Rajan?
A pathological fracture, sir.
Can you please speak loudly?
Pathological fracture, sir.
Pathological fracture. What kind of pathology you are
Pathological
suspecting?
fracture, yes, but what is it likely to be?
Is it likely to be a bisphosphonate fracture or typical fracture?
So atypical fracture, sir.
A typical fracture. What about Rishu?
Rishu, Subhanshu, everyone is there.
Likely to be a typical fracture.
Sir, it is due to he or she is on a PPI, sir. So that's why hypochlorhydria, and due to use of PPI, there is a atypical fracture, sir.
Due to what?
Due to, sir, uses of PPI, sir.
Why?
Yeah, but what does that lead to?
Is a typical fracture common on medial side or lateral side?
Sir, on
Back
the
to basics.
So insufficiency
that-
fracture and atypical fractures are two different things, okay? So don't mix the two.
So this is very likely to be, or rather diagnostic of insufficiency fracture because of osteomalacia. Okay, medial aspect. Lateral would be atypical. Okay, so these are her reports. Her calcium is 8.01, vitamin D is 17.5, rest is normal. Now this is my question. She was started on this treatment somewhere else by a friend of mine, calcium citrate maleate with calcitriol tablets. You can see these tablets. I have taken out the brand name. But after 3 months, her levels of vitamin D were unchanged. And she was extremely furious. And that is the time when she approached me. Now what should I do? The person had diagnosed her properly as insufficiency fracture because of vitamin D deficiency. And Subbu, please start your video. Yes, Rajan. Her vitamin D levels were unchanged, and then she was very upset with that surgeon. And then she approached me. What should I do? Should I change her vitamin D medication? Should I do some more investigation? Should I change her calcium preparation? See, the title of this talk is Back to Basics. So think of absolute basics. Think of basics. Levels are unchanged. She is very upset.
Adish,
Yes, sir.
Yes.
Yes, Adish Jain. Why are the levels not changed and now what should I do? Okay, I'll give you a clue. I said, how are you? So she said, I am fine.
Yes.
I am fine. So I repeated her x-rays and these are her x-rays. She has no pain. Fracture is united. But still she is very upset with that surgeon. So how can you explain? The levels are not changed. She has improved. So she says, how do I know that I have improved? My levels are still low.
So
Bolo.
look at the X-rays carefully.
So there is
So no doubt she has improved, correct? तो फिर levels उतना ही क्यों? Levels इतना ही क्यों? Again, back to basics. Levels उतना ही क्यों? This is what she is taking. This is what she is taking. Are the levels going to change or they are, I will say, I'll give you another hint. The levels are not going to change. Why? कितना भी 4 महीना ने 15 महीना खाने दो. Levels will not change. क्यों? So what levels do you measure in vitamin D? When we ask for vitamin D, what is the compound that is checked? What is
Rishu
it
has
that you
written
check?
something.
What is
Rishu,
it?
What is calcitriol? Down to basics.
So calcitriol is 125 dihydroxy
Correct.
cholecalciferol.
And what
Correct.
are you measuring?
vitamin
So,
A.
so we measure 25 hydroxy levels.
Correct. Why?
So,
Why do you measure that? Why not measure 125? Why not measure? That's the most active form. So it is most natural that you check active form, isn't it? काय को precursor करने का? For thyroid you check T3, T4. Correct?
Yes, sir.
So why do we check 25 hydroxy? So what is the difference between levels of 25 hydroxy and 125 hydroxy?
Sir, 25 hydroxy is synthesized in liver and then it is
Yes.
carried to the kidney for one hydroxylation, finally
Correct.
making it 125 dihydroxy
Perfect.
cholecalciferol.
Perfect. So which are the factors which facilitate or influence this?
Kidney function.
So it's a body mechanism, isn't it? Correct? It's a body's mechanism to keep 125 levels normal. Understand? Because it is a hormone. Now today kidney is also considered to be an endocrine gland. Bones and kidneys. So kidney secretes this hormone based on calcium and PTH values, based on body's homeostasis. So 25 hydroxy is a true body store. True body store. The level is almost 1,000 times that of 125. Samjhe? 25
Yes.
hydroxy is so much. Based on body needs, 125 is secreted and that levels are generally kept normal. But that doesn't tell us whether body stores are appropriate or not. And PTH value is generally inversely proportional to to the 25 hydroxy. So as 25 hydroxy starts going below 30, PTH level rises and causes resorption of bone, which you want to avoid. Samjha? Which you want to avoid. So that is why we check 25 hydroxy. That is one reason. So it is a true store of vitamin D. Number two, it is a much stabler form. 125 is very unstable. The half-life is very small. So checking it is not very easy. But the most important reason is, as I said, we need to know the body stores. That is why. So 125 is being supplied by your calcitriol directly. Correct? It is not passing through 25 phase at all. So body stores are remaining same. So 25 hydroxy level remains same, but patient improves because you have given calcitriol. Correct? आई बात समझ में? Rajan, you are with me or no? Let me know. If you are not clear, I'll explain again.
I think it's important that you understand this properly, because otherwise you'll always be confusing things.
Give me a minute. I will just share something else. ये देखो. So skin and gut give you D3 and D2, correct?
Excuse
It
me,
goes
sir.
to.
We're not seeing the.
Oh, sorry.
We're just seeing the
Folders.
presentation is not opened.
Can you see now?
Yeah.
Yes,
Yes,
sir.
sir.
So the skin gives you D3 because of sunlight. Gut gives you D2, that is plant D3. It goes to liver and it gets hydrolyzed by 25 hydroxylase. So what comes out of liver is 25 OHD3. It comes to kidney, which changes it to 125 dihydroxy in the blood. Correct? Now, if you give 1 D3, what is called 1 alpha, or you give, now here, the metabolite most commonly checked is 25 hydroxy. Can you see that? Which comes out of the liver, which represents the true body stores. The level is 1000 times more than 125 hydroxy. Okay. So, if you directly give 125, barabar, it goes directly to the bloodstream. Correct? It is bypassing the liver totally. So whatever 25 hydroxy is being prepared by your liver remains the same. So the level of 25 hydroxy does not change, but patient improves because you have directly given 125, bypassing liver and kidney. आई बात समझ में?
Yes, sir.
Rajan, clear?
Yes, sir.
Okay, thank you.
So back to that X-ray now.
Yeah, back to that X-ray. अभी किधर गया साला X-ray? No, I think back to basics. Can you see now? Back to
You need
basics.
to actually full screen.
Yeah.
It's not, yeah,
Okay.
now it's okay.
Now this we will skip for the time being. I'll show you another case now. Okay. This is a 25-year-old girl. Okay. She has pain all over the body. X-rays are reported. I would like you all to read. But I would like to ask you this question. These are our values. I was sent for a second opinion because all the investigations were within normal limits except slightly low calcium. So can you comment on that? Adish, Rajan, Subbu. Now, question 1 is, please read the X-ray. What would be your spot diagnosis? And second is, what do I answer? I was sent for a second opinion because the primary surgeon said that all the investigations are almost normal.
So,
Will diagnosis, spot diagnosis, spot diagnosis.
so basically, does the bone look normal to you guys?
Fuzzy bone, anything else?
Look at
There are
around
two
the pubic
small
symphysis region. Look at the SI joints. Look
SI
at the
joint.
femoral heads.
You think SI joints are dislocated? Bilateral subluxation of SI joint, pubic symphysis diastasis, something funny on the medial aspect of the neck, something funny at the facial level of femur. कुछ तो गड़बड़ है ना? So is it osteoporosis?
Osteomalacia.
Osteomalacia. Perfect. So what are these signs that we talked of? What do you see in SI joint? What do you see on in pubic symphysis? Can you see distinct widening there?
Yes, sir.
Okay. I will show you the next X-ray. See this. This is after treatment. Can you see the SI joint now? See this and see this. See the pubic symphysis and pubic symphysis here. So these are some of the very common signs on X-ray of osteomalacia. Widening of pubic symphysis, widening of SI joint. Samjha? Then here you can see a small lytic zone, which is likely to be a insufficiency fracture again. And see the bony architecture. बराबर? कुछ तो गड़बड़ है कि नहीं?
Yes, sir.
So this is classical osteomalacia. Now my second question. With so much osteomalacia, how can our investigations be normal? Again, back to basics. Again, back to basics.
So what are you measuring?
So because serum vitamin D levels are again telling us about the 25 hydroxy vitamin levels rather than the active form of vitamin levels.
Hey, but this is what we measure, and that is what we want to replenish, isn't it? So that suggests body stores. So that is 44.
So what's happening?
So, sir, So 25 hydroxy might not be getting converted into the active form.
Possible.
Why is that happening?
Anything else? Anything else? Again, back to basics. Absolute basics. Okay. Now read this unit. There are two different ways of expressing 25 hydroxy. There are two different types of laboratories. Some talk of nanograms and some say nanomoles. Okay. So this 44 is actually nanomole and not nanogram. Understand?
Yes.
So there is a famous lab which has several centers. One of them is Lal's lab and the other one also I forgot. Both of them give expression as nanomoles. Nanomoles and not nanogram. Understand? So if it is 44, sorry, 54, whatever, that is actually 1/3. You make it 1/3 and that is nanogram. See this?
So the normal levels for the Lal lab is 75.
75.
Which corresponds to 30 from other labs, yeah?
Other labs.
Hmm.
So you need to check their normals and check their unit. Always check the unit. So for Lal lab, it is 75 to 250 or to whatever, 175. 75 to 175. Samjha? So when you have this report as 54 nanomoles, is actually 18 nanograms per ml. And that is significantly low. Okay. Again, you are all with me?
Yes, sir.
Okay. So always check the units of vitamin D. Okay. Now, this patient had significant hypoproteinemia. Do you think the calcium level that is expressed here will change? Her albumin level is say 1 instead of 4. I'm just giving a hypothetical figure. So the calcium levels will have to be changed. Calcium level is same. If somebody has severe hypoproteinemia, does the calcium level change?
Yes.
So in short, protein,
Yes, sir.
lot of calcium is bound to protein. And for every gram of low albumin, you have to add 0.8 milligrams of calcium. So if the difference is 3, then you add 2.4 and that is your corrected calcium. So as a rule, whenever you have a patient of significant osteomalacia, check for serum proteins and then you will get your appropriate calcium level. Okay?
Yes, sir.
Okay. Now, what calcium would you give? There are hundreds of calciums, right? Yes, sir. What will you like to give? Which one will you like to give? Calcium sulfate? Calcium sulfate?
The calcium carbonate.
Calcium carbonate. Perfect. Why? Why?
Why?
Why would you give calcium carbonate? Why would you give calcium carbonate? Why not calcium sulfate? बराबर की नहीं? Why not calcium lactate? Why not calcium citrate? Why not calcium phosphate?
So because carbonate is more readily absorbed via the gastric route.
Sorry. And the concentration of calcium is most there. Na? 40% calcium. It contains 40% calcium. Citrate contains just 20% calcium. And citrate is easily absorbed. So what is the downside of carbonate? Downside of carbonate. Gastric upset is very common. Bloating, constipation, vomiting is quite common. Many people don't tolerate carbonate. So that is why the next one in line is citrate. Only thing is you need to give more doses because it's about 20% only. Okay. So I will go to the next case now. This man presented with a sinus and 2 scars. Has pain in the elbow, discharged from right olecranon for 1 month, stiffness for 18 months, and that's the X-ray. This is 5 months before he presented to us. He had an abscess which was drained elsewhere. The culture was negative, and then he developed a sinus. A swab taken from sinus grows methicillin sensitive Staphylococcus aureus. And since then he is on antibiotics. Abhi mai kya karu? This is at presentation. Inflammatory markers are raised. That's the MRI. I'm sure you'll ask for an MRI. Now what should I do? Should I continue his MSSA antibiotics because he has been on, the swab was MSSA? Should I aspirate or should I do an FNAC or should I do a mini incision biopsy? If it turns out to be COX, it will respond to ATT or I operate with the idea of doing full debridement, exploration and debridement. What should I do? Kone Subbu? Mr. Subbu, आपका वीडियो चालू करो.
Sir, I
What
will
will you do? Adish, what will you like to do?
Three.
3, operate, full exploration and debridement. Why not continue MSSA? You already have a microbiological diagnosis. You already have a diagnosis. So why would you like to not continue that? बराबर कि नहीं?
Yes.
MSSA आ गए, sensitive bug.
You've all seen the clinical picture, haven't you?
Yes.
by exploration and debridement, we will decrease the bacterial load. If there is any dead tissue, we will remove that.
Okay. But if it turns out to be TB, then it should respond to anti-TB drugs, isn't it? I will show you the this thing again now.
Clinical picture and X-rays.
Clinical picture and X-ray. I don't know, this is getting long. That's the clinical picture. You can see a sinus there and 2 scars, and that's the X-ray. That's the MRI. swab was taken from here, which turned out to be MSSA. So why not continue MSSA medicines is my question. Back to basics. Why not continue
We've all
MSSA
seen the
medicine?
X-rays and the MRI plus the clinical picture. So what did you see on the X-rays that should worry you?
Sir mentioned repeatedly that he has taken the culture swab.
I think we've been through these multiple times that the culture swab doesn't tell you anything. Yeah.
Swab is not that effective, sir, and there is a dead bone, sir, that in X-ray.
No. 1 minute. Swab is not that effective means what? Means
You're
what?
asking for trouble.
It is not reliable. What you want to say is it is not reliable because the skin organisms are there. Na? MSS is a skin organism. Barabar ki nahi? So
Yes,
what
sir.
you really want to find out is a deep sample. Correct? So swabs are generally unreliable. They do not, the concordance between swab and deep culture is to the tune of 15-20% only. So one should not believe a swab. Okay? Now the X-rays. So if it turns out to be TB by say an FNAC or by a needle biopsy, will you like to start TTT or would you like to operate? In short, what are the indications for surgery in tuberculosis of the elbow? So is there any difference between tuberculosis of the spine and tuberculosis of peripheral skeleton? What do you want in spine? You want stability. What do you want in peripheral skeleton? You want mobility. Correct? You want your elbow to be mobile. So is there any classification that helps you to decide in a Cox elbow whether to operate and do debridement or not? So in short, suppose it is only a synovial lesion. The articular cartilage is not involved. On MRI, you pick up synovitis or synovial hypertrophy, hardly any changes in the bone, then it is very likely to settle with anti-Cox treatment. Or there could be a metaphyseal lesion which has not burst into the joint. While here, you can see the lesion has burst into the joint. Can you see this olecranon? Which has burst into the joint. So once it bursts into the joint, the chances of articular cartilage damage go up significantly. And therefore, you need to operate. Correct? So,
and also if you look at the X-rays, the articular cartilage is probably already damaged to some
already
extent.
damaged. Already damaged. So is there any classification? So this is a very nice paper. All of you should read, published by Dr. Dhillon long ago, I think 2012, 12 saal pehle. So in short, if it is only synovial, see this, only synovial, then one can give only anti-TB drugs. If it is swollen for 2-3 weeks, then, and no bony involvement, again, you can afford to the differential diagnosis would be acute septic arthritis, Cox, or trauma. Crystal arthropathy. So you start with NSAIDs, steroids, aspirate, and then take it further. Then you will have acutely swollen joint or swollen joint for 3 weeks or more. And MRI shows infective lesion and hypertrophy, but no bony involvement. Either arthroscopy or ultrasound guided biopsy. If it shows synovial effusion and a bony focus, as you can see here, is a bony focus, but which has not burst into the joint, then the articular damage is less likely. Then this could be either septic or Cox, and then generally do an arthroscopy and then probe the focus. But in this case, you have a lesion which has burst into the joint. Here I have shown in humerus, but we have a lesion in the olecranon which has burst into the joint. Correct? So this is a case which has to be operated. Whether it is TB or whether it is septic, once you have already got an articular cartilage damage, you try and salvage it as much as possible. And of course, it is totally arthritic, then you may not be able to salvage the joint, but still something needs to be done. Maybe fusion, maybe like here, it is totally destroyed. Then you need to do either fusion or excision. You will not be able to salvage the joint. So in this case, we had to salvage the joint. Okay, so that's the roadmap. Stage 1, synovial hypertrophy. Stage 2, extra-articular involvement. Stage 3, extra-articular involvement, which is threatening to break into the joint, or there is already an intra-articular involvement. That is stage 3, and like this case, and it has to be operated. Okay? Stage 4 is gross destruction. Surgery doesn't help range of movement, but may be needed for other reasons. So that's the incision, because you have to approach the bony lesion and excise the synovium also, isn't it? So that's the bony lesion. Here you can see pus deep inside. And this we had discussed couple of times as to what all investigations to be done. Now here, patient had pan-sensitive TB, and we continued all the drugs. That's at 12 months, almost full pronosupination and a decent range of movement.
So just one statement, Vikas, you said surgery will not affect range of movement. It should be, may not affect range of motion.
Yes. When the
sometimes get good movement, but
correct,
you cannot
correct,
assure
correct.
that, and that
Correct.
should be very clear to the patient.
Right. So, any questions, or we go to another case?
One more
So,
case, sir.
One more case.
yeah,
Okay.
but we'll have to be quick because we don't have that much time.
Okay.
What happened to that first case that you showed?
Konsa?
No, the first one. You showed the healed fracture, but still having pain then.
No, she had no pain. That's what I
Oh,
wrote. She had no pain. She was furious only because the levels had not
Oh,
gone
okay.
up. So, she just needed explaining that the levels will not go up. She was otherwise very comfortable.
So would you do something to get the levels, the stores down up to normal?
So, whenever you give calcitriol, it's always better to give the
Vitamin D as
usual
well.
calcirol also, cholecalciferol also, so that the levels come up. समझे क्या नहीं बच्चे लोग?
Yes, sir.
The levels have to, so you manage the levels also, correct?
Yeah,
Okay.
because that's what affects the PTH. That's also important.
Yes. Okay, again, a simple case. 22-year-old boy presented with persistent sinus in the middle third. Can you see this? For 6 to 8 weeks. He had RTA 10 weeks ago, had a segmental fracture tibia. Proximal third was closed. Middle third, this fracture was open. And the relative said that a small spike of bone was visible through the wound. Okay. Day 1, debridement and suturing of the wound was done. Day 8, internal fixation was done by lateral anatomical tibia plate, and middle third was MIPO with 11 holes LCDCP. And this is when he presented to us. This is the area where MIPO is done. That red thing, red circle is, you can see 2 small stitches. This is the area of open injury where the bone head was visible through this, and this is these black circles are the area which were utilized for MIPO. So that's the upper incision, that's the middle screw, that's the lower screw. Okay, and that's the proximal part. So he developed discharge at about 3 weeks after injury. Swab was negative. He was on several antibiotics, 3rd generation, amikacin, linezolid, metrozil. At 8 weeks, he developed swelling around the distal incision, which burst. The swab was pseudomonas. He was on piperacin, tazobactam, and meropenem. But the discharge was persistent, and that is why he presented to us. This is how he has presented to us. That's the MIPO ka upper incision, that's the MIPO ka lower incision, that's the area where bone had come out. That's the 11-hole plate that was inserted. He had very little pain, had a decent range of movement. The reduction obviously is good, probably stable. He had a small discharging sinus for 8 weeks and unhealthy distal incision, which also is discharging. So, what should I do? Continue piperacin, tazobactam, modify antibiotics, collect new sample from sinus, excise, explore the sinus, debride, excise the sinus, and remove the plate through MIPO or any other. I will go back. This is where we stand. Anything that strikes you, something odd, anything that strikes you. Okay, abhi dekho, the bone had come out from here, right? So this is the area where infection has entered, contamination has entered, and you have discharging sinus here and here. So what does it suggest? Does it suggest something? Does it suggest something? This area and this area are discharging, while the point of entry is here. Means what?
Did we see this case before, Vikas, by any chance?
You have probably seen.
Yeah, I've seen it somewhere.
You have seen it somewhere. I think one of the meetings that we had conducted. Either, I don't remember where. I'm sure maybe at Ayocon you were there?
No, I maybe Ahmedabad, the last Otis call.
Maybe I don't remember, but I'm sure you have seen this. I'm sure you have seen this. So think why should there be infection at the upper MIPO part and lower MIPO part? When it is possible? When is it possible? So the entry has occurred in the medullary canal and the infection is coming out from the MIPO incision. That means the entire tract at 3 weeks discharging sinus in proximal part, at 8 weeks the infection in the distal incision. Several antibiotics were tried. The suture line of index wound did not suggest that extension and excision of the wound was done. That means what was done was only ऊपर से 2 टाका लगा दिया. Correct?
Inadequate debridement.
Obviously, it was not extended and the medullary canal was not cleaned. Barabar. And then that means there is a high chance that this entire thing is infected. समझा क्या नहीं? Now I would request all of you to start your videos again and tell me if you have understood this, because it is very, very vital. समझा क्या नहीं? The entry has happened here and sinuses are here. That means अंदर से infection has to be there, isn't it?
Sir, but then why it is not, there is no, sir, infection at the entry side?
Absolutely.
Fracture side?
Perfect question. Possibly, this was a area of less, what should I say, resistance. Possibly. So I totally agree with you. There should be infection discharging sinus here also. Agreed. But then the reduction is so good that probably it didn't come out. But again, I am absolutely with you. But still, if there is a discharging sinus at proximal and distal end, the entire inner medullary canal or underneath the plate has to be infected. Otherwise, why would you get discharging sinus there? बराबर कि नहीं? Why it did not appear here is, I don't know. I mean, we cannot really explain. Absolutely correct. So, what we did was something new. This FDG labeled leukocyte PET scan, which is available only in 3 centers in India. Fortunately, we have it. So we withdraw WBCs and label with 18F FDG and then re-inject. And they go to the biofilm attracts them. And here you can see the entire thing, this yellow thing is the infected thing. So it is underneath the plate. That's the plate. It is underneath the plate. And these yellow bright things you can see are the areas which are infected. So the entire medullary canal was infected. Also, funny thing here, you can see that's the something like a sequestrum, and that's the callus going on both sides, which is bridged, not bridged. This part is coming out, and here you can see that's the tibia, that's the fibula. Through the intraosseous, over the intraosseous membrane, there is infective lesion in the anterior aspect of fibula also, which we would have definitely missed with MRI, with so much metal. Even if you use a Mars MRI, very likely that we would have missed that. So that's our thinking. So obviously the implant has to come out because there is infection here, there is infection inside. Barobar? So intramedullary debridement was needed. How to do it was a question, but that's our incision excising all the, that's the MIPO area, that's one screw, that's the entry wound. These are all the screws that, small incisions that were used for MIPO. So this entire area was opened, excised. That's the proximal areas which were excised. And here you can see underneath, once we removed the plate, absolutely cortex was totally destroyed. So that is the problem with grade 1 or grade 2 open fractures, that unless you extend the wound, deliver the fragment into the wound, clean it very well, in fact, convert it into type 3, but a clean type 3, and then put it back. Moment you just seal the upper skin by just suturing, taking 2 stitches, the contamination remains inside. And here you can see we could just use a mosquito and take out, open the cortex. And that's the medullary canal, which is absolutely covered with dirty granulation tissue. And we had to make a 23 centimeter window. But fortunately, there was hardly any movement at fracture site. And the patients and relatives had said, we don't mind minimal malunion, but we don't want any kind of internal fixation. So this is the fibular lesion which we opened. That's the proximal incision. This is on day 5. You have a large, complex defect. So you need a flap. And the best flap would be a micro flap. So that was done. And culture was pan-susceptible Pseudomonas. And the histopathology showed granulomatous tissue. So both Pseudomonas as well as NTM were treated. And that's at 12 weeks. He has already started healing. And that's at 10 months. Very, very comfortable patient.
So in this patient, sir, initially MIPO shouldn't have been done in the
Correct.
first place.
First place, appropriate debridement had to be done.
Debridement, that's the most
That is
important
the
thing.
first and most important thing. The problem is, we keep saying that the treatment of open fracture tibia is nailing. No, it is debridement, 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 and then
nailing.
think of nailing.
So also,
Unfortunately,
when you say that it's grade 1 converted to 3, it was grade 3 in the first place because it's not really the size of the wound, but the
Correct.
amount of soft tissue injury
Combination.
that is really the
Correct.
answer to your grade of Gustello-Anderson. And this is an
Correct.
often misunderstood concept that the wound is really deciding the grade of the fracture,
Fracture.
grade of the open injury. Yeah.
So extend the wound, excise the index wound, excise. You need to extend so that you get a surgical approach to for excision of that wound, in index wound, and then close and then think of whatever you want to do. In case you want to do internal fixation with the same sitting, take out all the drapings, take a new tray, drape again and do a nail. So consider these as 2 different operations in the same sitting, of course. The problem is we just close the wound by taking 2 sutures. In fact, the junior most person is told ki are jara debridement suturing kar de, I will come for nailing. The registrar tells ki main nailing ko aata hu. That is the problem. Any questions?
I have to get my
I think it is great, sir.
started.
listening to you again. And if anyone has some question, please ask now, so that.
Yeah, so thank you very much, Vikas. That was
Thank you.
excellent.
Thank you.
And
So, most important is don't take grade 1 open fractures lightly.
yeah, and this is,
Especially when you are doing an internal fixation. Especially. Okay.
and I think
That
no,
is,
I think I would change that slightly. I think don't take grade one, what you call grade one lightly. Don't take a puncture wound lightly,
correct.
okay? In an open
Lightly.
fracture.
Or
Because
open fracture with small wounds lightly.
it could
In
be just
fact,
like a tip of a glacier or
yeah,
whatever.
absolutely. Very, very risky. Open everything. Excise everything that is infected, contaminated, dead, loose, all the contamination, especially on the inner aspect of your bone, have to be covered. Invariably, many people give a forceful wash in casualty, contamination goes in, or a bone which is protruding is pushed inside. That carries lot of contamination inside. So increase the incision, dislocate that bone into the wound, go deeper side, clean it up, and then बाद में जो करना है वो करो.
Great, thanks
Okay.
very much, Vikas. Oh,
चलो,
sorry.
bye bye.
Bye, and till next week, everyone.
Yes.
This is, I'm sure all of you have learned a lot from this discussions and talk today, and as usual, excellent cases to sort of
Thank
illustrate the point
you.
that he's trying to make. So great, Vikas, and thank you very much, and see
Thank
you all
you,
next
John
week
and
again. Okay,
Janki.
bye.
Thank you, John,
Bye,
for
Vikas.
being there even
Yes.
when you are in US.
No, it's well, the timing was actually not so bad because it's
Acha.
8:30 in the morning, so it was okay.
Ah, good, good.
Okay, bye.
चलो, bye bye बच्चे लोग.
Thank you so
All the
much.
best.
Thank
All
you,
the
sir.
best. Bye bye.